Good afternoon. Today's topic is syphilis. It's a sexually transmitted disease. The causative bacterium is Treponema pallidum. Then transmission is through either by sexual contact or congenitally, that is through the placenta or the fetus, the birth of the from infected mother. Different manifestations according to the stages, that is signs and symptoms: primary, secondary, latent, tertiary, congenital and early stage. Primary, it is the first stage after infection, painless, localized ulcer with a rolled edge, single or multiple, appear 2 to 3 weeks after contact. Most common sites are cervix, vagina, vulva, nose and mouth. Regional sites are becoming enlarged. And primary syphilis, the cancre incubation period is about 9 to 90 days. 21 days develop at the site of contact or inclusion. Classically, single, painless, clean based durated ulcer, mostly anogenital, but may occur at any size site. It is tongue, pharynx, lips, fingers, non-tender regional adenopathy, very infectious, may be dark field positive but serologically negative. Then secondary, the skin rash diffuse, often with a supraficial scale. Then may leave residual pigmentation or deep pigmentation. Condylomata, that is formed by Coulson's large, pale, flat-topped papules, occur in warm, moist areas. Mucosal lesions, 30%, that is occur mucous patch. Then secondary syphilis, systemic 1 to 6 months after contact, fever, malaise, general adenopathy and non-itching. Maculopapular, skin rash, then involve the palms, hands and soles of the feet. Mucous patches and linear snail track. Then secondary syphilis in 6 weeks to 6 more after primary cancre, usually with diffuse non-pruritic indurated rash including palms and soles. May also cause fever, malaise, headache, and according to the system you can write. Then secondary syphilis, differential diagnosis. The rash may be confused with the Triasis rosea, that is usually hard patch, that lesion seen along the lines of skin cleavage. Drug eruptions, acute febrile xanthums, psoriasis, lichen planus. Then scabies, the mucous patch may be confused with oral thrush. Then latent syphilis, positive syphilis, that is a serologic without clinical signs and symptoms. It begins with the end of a secondary syphilis and may last for a lifetime. Patient may or may not have history of primary or secondary syphilis. Diseases known to cause occasional false positive non-treponal test reactions for syphilis, such as systemic lupus erythematosus, congenital, divided early and latent stage 8 latent syphilis. The first year after the resolution of primary or secondary lesions, a reactive serologic test for syphilis in an asymptomatic individual who has had a serologic test within the preceding year. Then latent, that is non-infectious. Latent syphilis, tertiary syphilis, that is it is the destructive stage of the disease. Lesion develop in skin, bone, then visceral organs or any organ. The main types are late benign. Cardiovascular neutrosyphilis can be crippling, often life-threatening. Blind, deafness, deformity, lack of coordination, paralysis. It is usually very slowly progressive, bearing certain neurologic syndromes. Latent syphilis is non-infectious. And latent syphilis, this the latent, the slide is previous slide only, no need of much explanation. That is the physical, that in tertiary syphilis occur 1 to 10 years after an infection. Gummas, ulcerative nodule of the skin, bone and nervous system, hypersensitivity reaction, systemic manifestation, CVS, CNS and bone, congenital syphilis, mode of transmission, transplacental passage from infected mother at birth, congenital infection associated with several outcomes, low birth weight, congenital anomalies, premature birth, miscarriage or death of the baby. Congenital, these are the symptoms. Laboratory diagnosis, primary syphilis, serous fluids. Then humor antibodies, and 30% of these early primary syphilis and non-treponal test results. Definitive diagnosis. For persons with a history of syphilis, 4-fold increase in titer quantity. And suggested diagnosis, the presence of lesion, sexual contact within the preceding 90 days with the person with the syphilis has been diagnosed. And MHA-TP is less sensitive than FTA-ABS test and non-treponal test. Secondary syphilis and serological test. And with a definitive diagnosis, observing treponema pallidum microscopic examination. Presumptive diagnosis, that is pickle lesions and reactive non-treponemal test titer. For persons with a history of syphilis, 4-fold increase most recent titer compared with the past test. For patients with atypical lesions or non-treponemal test, titers is less than 8. Sensitivity. Then suggested diagnosis, serological test and not available is based on both the presence and clinical manifestations and sexual exposure within past 6 months. Latent ആണെങ്കിൽ presumptive diagnosis only. That is the otherwise serological diagnosis results. Then 4-fold increase. Then tertiary, approximately 30% of syphilis may be non-reactive. Treponemal test, syphilis, പിന്നെ serological testum പറയാം. Then also treponemal tests are always reactive and maybe only on the basis for diagnosis. Then neurosyphilis, CSF examination should be done. That we have seen that tertiary, I think so. There we are for access the CSF. Then diagnosis, that is in the CSF fluid, cerebrospinal fluid, we are assessing by tapping the lumbar puncture and we are getting the cerebrospinal fluid. If the bacteria presence is that, what type of bacteria and what is will be the diagnosis also we can confirm. Then neutrophils, that is how the reaction. Prevention, the first choice of prevent manifestation is syphilis is penicillin. Parenteral penicillin G is the only therapy with a documented effective during pregnancy. Non-pregnant individuals who have severe allergic reaction to penicillin may be effectively treated with tetracycline doxycycline. Okay, thank you.